Just to warn you all, this introduction takes a while because Liz has done an awful lot in her career. I learned looking through her CV actually that she was born in Dublin, and so that's an interesting Liz tidbit that you should pester her with questions about to explain that origin. But to get a little more serious, after Liz came over to this side of the pond, she took a bachelor's degree at Yale and then completed her MD at the University of California, San Diego. Came up here to UW to do internship and residency in the Department of OBGYN, and then went off to St. Louis for a fellowship in the Division of Gynecologic Oncology at Washington University. She came back this direction and starting her faculty career. So at UW OBGYN as an acting assistant professor originally in 1999 and assistant professor really shortly thereafter. Then she started an extremely long list of different responsibilities and appointments here at the university and at the Hutch. She was made an affiliate investigator in public health sciences at the Hutch in 2001, was medical director of the breast and ovarian cancer prevention program at SCCA between 2002 and 2018, an adjunct assistant professor in the Department of Medical Genetics beginning in 2003. And then at the end of a series of promotions and responsibilities, became professor in the Department of OBGYN at UW and adjunct professor in the Division of Medical Genetics. That saga, as I left kind of things out of different and increasing responsibilities, has included being director of the Division of Oncology in the Department of OBGYN, co-leader of the Breast and Ovarian Cancer Research Program through the consortium, member of the Brotman Beatty Institute, and Liz has always been very attentive to teaching, and she's been co-director of an oncology T32, and she's now deputy director of the Cancer Consortium. Honors or another extensive list, and I've just picked from among the list. Um, Chief Resident Teaching Award at UW in '96, Kimmel Scholar Award from the Sidney Kimmel Foundation for Cancer Research in 2002, the Margaret Greenfield Carmel Cohen Excellence in Ovarian Cancer Research Prize from the Gynecologic Cancer Foundation. Several times she's been mentioned. So, where'd that come? Mentioned as a top doc in Seattle Magazine and also Seattle Met Top Doctors Award. Still plenty to come. Genome Advance of the Month from NHGRI in 2012. Rosalind Franklin Award for Ovarian Cancer Research from the Ovarian National Alliance in 2013. Resident Research Mentoring Award. So again, attention to mentoring and teaching. Exceptional Women in Medicine, Castle County, or Castle Connolly back home, and a Top Doctors Award there. UW Medicine Award for Excellence in Mentoring of Women Faculty, and the Society of Gynecologic Oncology Innovation Award just in 2021. As I said, this is a summarized list. But we do have to leave time for Liz to speak, so we'll stick with that summary. I think, as all of you know, joining here, the primary focus of Liz's lab has been the molecular genetics of ovarian cancer with a goal of improving both prevention and treatment. She's been closely involved with the development of PARP inhibitors as therapies for ovarian and other cancers. And she's also focused on improving our understanding of genetic risks of ovarian cancers with the goal, of course, of increasing access to genetic testing and reducing the number of women who die of hereditary ovarian cancer. And the title of her talk today is Understanding Ovarian Cancer, A Journey to Personalized Prevention and Treatment. And let me say, just as a housekeeping thing, we'd appreciate it if you'd put your questions in the Q&A portion. And if they seem to need to be brought up right away, I'll pop in, Liz, but otherwise we'll take them up at the end of your talk. So take it away. Thank you very much.
Thank you, John, for that really nice and extensive introduction. I realized when I was putting this talk together, I couldn't decide exactly on what to focus, and that I would sort of give an overview of my journey. And anytime I think that you put journey in the title of a talk, it shows how long you've been around. It's really an honor to be here. I've heard some of the greats in science give this science and medicine lecture over the years, and it's really incredible for me to be giving this to you right now. So I'm a gynecologic oncologist, and I just was going to let you know that this is a kind of unique specialty in that we take care of the female cancers below the belt. We do both surgery and chemotherapy, and it's the only specialty of which I'm aware that really addresses both of those areas. And we also provide palliative care as well. So I went into medicine because I really wanted to be a clinician scientist. I was drawn to the research. I loved oncology because I had the idea that I would be able to bring things from bench to bedside, which is kind of like a typical thing that we say about translational research. But in reality, I think the reverse is true for clinician scientists, is that it's honestly your observations clinically that drive a lot of your questions. And I hope that I'm going to kind of display that for you today. And an alert is I do mentor a lot of clinician scientists who are honestly asking me for advice frequently. And I'm going to drop a lot of tips for clinician scientists along the way things that helped me through my journey. So I came here in 1999, as John said, to join the Women's Reproductive Health Research Program, which was brand new at that time. There were 4 initial scholars. One of my co-scholars was Susan Reed, who became director of that program more recently, and has taken care of that for the last 10 years. And these are people who've led that program. I had the choice of a number of mentors within that program to join up with. And the mentor that I hooked up with was Mary Claire King, who I think you're going to hear about throughout this program. So as most of you probably know, Mary Claire King discovered BRCA1, which is a gene that causes a high risk of breast and ovarian cancer. And when I went and discussed the possibility of working with Dr. King, I realized that here was an incredible opportunity. And my first tip for clinician scientists is find scientific mentorship outside your specialty. The opportunity to work with a world-class scientist outside of my specialty is really what's driven my entire career. So BRCA1 and BRCA2 mutations lead to a very high risk of breast and ovarian cancer, as shown here, with the green bar representing BRCA1 and the gold bar representing BRCA2. But with breast cancer on the left and ovarian cancer on the right. And so my next tip is take advantages of local opportunities and mentorship, because as a fellow, I had been working with Dr. Paul Goodfellow and studying endometrial cancer, which was a much smaller niche than ovarian cancer. And I felt like that was a place I could really make a contribution. But when I came here, nobody was really working on that. I interviewed with Mary Claire King, and clearly ovarian cancer was a great opportunity within her lab. Many people were sort of focusing on the breast cancer side, and nobody was really focusing yet as heavily on the ovarian cancer side. So I could bring something to her lab. And if my science didn't work out, then as you can see here on the right, then I was able to contribute to the soccer team. At this time, we were young enough to play on intramurals and compete with the undergrads and grad students, but those years are long past. So focusing on ovarian cancer, of all the female cancers, ovarian cancer has the highest mortality per case, as represented here. And so it is definitely a problem that needed to be addressed. And so what explains that high mortality? And the real reason is that 3/4 of patients present with advanced stage 3 or stage 4 disease. And if you actually look stage for stage, ovarian cancer has the same mortality as breast cancer. The difference is that our patients present with much more advanced disease. So this really was the first question I really wanted to understand is how do we get from an ovarian cancer cell to advanced ovarian cancer? What is that progression of steps? That drive to understand, to the mortality being so low for early ovarian cancer made people want to try ovarian cancer screening. And at that time, a lot of people were focused on ovarian cancer screening. And it wasn't clear to me that we were going to ever have effective early detection or screening if we didn't understand this, like these steps of pathogenesis. So my tip for clinician scientists is think of really important clinical questions. So I was drawn to this because of some of the work that had come from colon cancer had been around for about a decade, showing this progression in polyps from normal epithelium through early adenomas to hyperplastic disease to carcinoma. And the molecular steps were just being worked out in work first driven by Bert Fogelstein and others, and this has been expanded on a lot. And I, the linear part of me just wanted to do something like this for ovarian cancer. But when we were presented with this advanced disease, this is from surgery with the omentum entirely replaced by cancer, how do we identify a precursor lesion? We did have some specimens of stage 1 cancers that were banked, but they probably have a different biology than these cancers that present with advanced disease. So how do we understand the spread? And my next tip is to really follow your passion, because this is something that I just didn't want to let go of. And yet, how to answer this question was uncertain. So my next tip is follow your passion, yes, but find a practical project. And so at the time, promoter methylation had been described as a way to downregulate tumor suppressor genes. And BRCA1 had a promoter that was amenable to methylation. And so I started out in Dr. King's lab trying to understand BRCA1 promoter methylation, whether it influenced protein expression, as you see here on the right. And my question was, from the clinical perspective, can BRCA1 promoter methylation impact response to therapy? And does it change over time during treatment? And I'm going to come back to this because I'm going to go back to my question about understanding the origin of ovarian cancer. But at the end of the talk, I'm going to come back to this project. So another tip is it's really important as early as possible for clinician scientists to align your research and your clinical interests. And there was a high-risk clinic for breast and ovarian cancer that had been founded in 1997 by Julie Grelo. So remember that clinical testing became available for BRCA1 and 2 only in 1996. And Dr. Grelo already had the foresight to work on this prevention clinic, which we then moved to the SCCA in 2003 and renamed the Breast and Ovarian Cancer Prevention Program. This was the first multidisciplinary cancer prevention program at UW Medicine. And some of the original people are shown here, including the dear Dr. Roger Moe from surgery, and Robin Bennett in medical genetics, who were great mentors to me. So I did not necessarily love counseling women about prevention, but my research was in this area, and it really is important to align your research and your clinical interests. And so I dived into this clinic and understanding high-risk women and how to help them on their cancer prevention journey. So early in this time, high-risk women, we were already telling them that we didn't have effective screening, and therefore we were left with surgical prevention as a way to reduce their ovarian cancer risk. So for women with BRCA1 mutations, where their lifetime risk of ovarian cancer is around 40%, and the cancer itself is very deadly, we recommend that they have their ovaries removed at the time that the risk starts to increase. And so in 1999, soon after I had gotten here, there was a patient with a BRCA1 mutation, actually from one of Dr. King's families, who had a prophylactic surgery, and we found an early fallopian tube cancer, about 1 centimeter big. And that inspired our GYN pathologists, Dr. Rochelle Garcia and Dr. Nick Agoff at the time, to say, hey, that's interesting. Maybe we need to be looking at the fallopian tube more closely. And so they started serially sectioning the fallopian tube instead of just representatively evaluating the fallopian tube. and looking closely at the ovary, they started looking as closely as they could pathologically at the fallopian tube. And within just a couple weeks, probably this is, just really very good timing, they found a patient who had a pre-invasive lesion in the fallopian tube, so that the closer that you look, now you can find potentially another patient with a BRCA1 mutation at very high risk, this pre-invasive lesion that looked very much like high-grade serous neoplasia. So we looked at the series. So we started doing this serial sectioning, and then we reported our outcomes, which is that if at that time the rate of occult neoplasm in the first 120 patients that we looked at was 11%. So these were patients that thought they were going to have a preventive surgery, and then we were finding early cancers. Having a mutation and older age correlated with a higher risk of finding an occult neoplasm. And the rate of that was directly related to having a careful pathologic and surgical protocol. And if critically, the majority of the cancers, about 90%, occurred in the fallopian tube and not in the ovary. So this led to the establishment of a specific pathologic and surgical protocol, which we touted as some of the other leading institutions did as well, and became the standard of care for how to manage a risk-reducing surgery. But now this gave us an opportunity to understand the precursor lesion. So we had these early lesions, and in fact, you could find patches of P53 staining, so a clonal expansion of a P53 mutation, even before you could visually see neoplastic proliferation. And so this led to work led by Barbara Norquist and our pathologists, and also Joshua Press worked on this to understand that early transition from normal fallopian tube epithelium to malignancy. And this really changed the paradigm. I had been taught in residency that ovarian cancers, that's epithelial ovarian cancer, started on the surface of the ovary, the ovarian epithelium. But in fact, at least for the high-grade serous cancers, they probably almost all start in the fallopian tube. And we started to understand this transition from a P53 focus, or signature, as some people call it, to non-invasive neoplasia to invasive neoplasia. And so this did really shift the paradigm, but as a clinician scientist, then we want to bring it back to the clinic. And the question is, what are the clinical implications? So that's my next tip is anytime that we find something interesting, think about the clinical implications. So this led to the idea that ovarian cancer is a very heterogeneous disease, even epithelial ovarian cancer. It doesn't all come from the ovarian epithelium. And in fact, when we break it down by the different histologies of ovarian cancer, they each probably have a different origin. Endometriosis leads to both endometrioid and clear cell ovarian cancers. And then not that many cancers actually arise in the ovary themselves. Low-grade serous seems to arise from borderline neoplasms in the ovary. And mucinous ovarian cancer, much of what we thought was mucinous ovarian cancer in my day as a resident, actually turned out to be appendiceal cancer, with some rare actual ovarian mucinous cancers that probably do arise in the ovary. And each of those types of ovarian cancer have a different molecular pathway. They're driven by different driver genes. And therefore, we can't really treat them all the same. And this has implications both for early detection and prevention, but also for therapy. And so now we can really enter the era of personalized medicine for ovarian cancer. So I'm going to just deviate for a second here and say, at the same time that we were working in this area, the cost of DNA sequencing was falling. And the Human Genome Project, which cost about $100 million to sequence the first genome, occurred at the beginning of this century. And then over the course of the last 20 years, we've had an exponential decrease in cost. And so now it costs less than $1,000 to sequence a human genome. And that's radically changed what we're able to accomplish. So you can see here that there's a big fall right here in price. And so that was the advent of next generation sequencing. And so DNA sequencing up till that time had been done by Sanger sequencing, with some examples shown on the left. And so I actually remember as a fellow having to read off the gels like this, like the one you see on the far left. And then fluorescent automated sequencing came along, which kind of allowed the Human Genome Project to move forward because that increased the speed. But it was next generation sequencing that really used a whole different technology where we're sequencing many molecules all at the same time. And what that leads to is that you can see here on the left is that what we get is like words or like small pieces of DNA that we don't know how they line up. And so it takes a lot of computer strength and computational biology to basically align all those words into a meaningful book. But at the time, then we can sequence an entire book at one time instead of basically sentence by sentence, which is what we were doing with Sanger sequencing. So at the beginning of next generation sequencing, Mary Claire King and Tom Walsh in her lab developed a massively parallel sequencing platform called BRCA, named after Paul Broca, 19th century neuroanatomist, who first described familial breast cancer. So this would allow us to basically sequence all the genes known or suspected to cause hereditary breast or ovarian cancer all at one time. And BRCA, as they developed it, is able to detect all classes of mutations, which is really amazing. And some of the key people that worked on that in this project that we then applied to ovarian cancer are shown here on the right, which includes Ming Lee, Sylvia Cassidy, Alex Knorr, and Christopher Pennell in my lab. So over the previous 8 years, I had consented with the help of many people, again, shown here on the right. It takes many people to do this, so I don't want to say that I did this on my own, but I had consented over 300 patients with newly diagnosed ovarian cancer to the King genetic studies, with the hopes eventually of identifying which patients had BRCA1 or BRCA2 mutations. But at the time, sequencing was so expensive and slow, and I didn't have either the manpower or the money to actually be sequencing all those samples. So I consented those patients and kind of didn't promise them anything and held their samples. But then the technology and the specimen availability came together at the same time. So my next tip for clinician scientists is gather the biologic specimens, the patient participation, and careful clinical annotation, even if you don't have the resources at the time to do exactly what you want with the specimens. Having those specimens will provide the basis to get funding to do the work that you want to do in the next section. So we were then able to ask the question, can we define the genes that contribute to hereditary ovarian cancer and what fraction of cases it accounts for? And you cannot gather specimens without the participation of your clinical colleagues. So this is an older picture of the division in the days when we were able to gather without masks. We don't have a current one, but also there's many nurses, surgical technicians, pathologists, et cetera, who all kind of have to contribute to gathering these cases. So people have to get on board with you. So what are the genes that we wanted to look at? BRCA1 and BRCA2 are part of this Fanconi anemia BRCA pathway that are critical to DNA repair via homologous recombination. Biallelic mutation in many of these genes cause Fanconi anemia, a rare autosomal recessive disorder, which is characterized by bone marrow failure and hypersensitivity to DNA damaging agents. But monoallelic inheritance of many of these genes were known to increase the risk of breast cancer. Their role in ovarian cancer really wasn't understood at the time. So again, because we had these specimens available, Mary Claire King, we did BRCA first as kind of a proof of concept, published this in 2010, I believe, and was led by Tom Walsh to detect inherited mutations using the BRCA platform. And then I was able to convince Dr. King that the next project we should do is basically apply BRCA to ovarian cancer in all these specimens that I collected over the years. And we published this the following year. And then a number of follow-up papers by Katie Pennington and Barbara Norquist working on this to define mutations in these genes in ovarian cancer. And this is work by Barbara Norquist, where she sequenced over time beyond just the cases that we had in our bank, but looking at patients that have participated in national clinical trials with ovarian cancer. And she sequenced nearly 200 patients with ovarian cancer. And we determined that approximately 20% of patients have mutations in genes that cause hereditary ovarian cancer, about 15% in BRCA1 and BRCA2, and another 4 to 5% in one of these other genes. And remember that these patients are not selected by age or by family history. So this is an unselected group of patients with ovarian cancer. And of those patients who had mutations, the majority of those cases did have mutations in BRCA1 and BRCA2. But the other important genes were these genes in the Fanconi anemia pathway shown here. The next most common gene was actually BRIP1. And the DNA mismatch repair genes shown as MMR, the 4 genes that cause Lynch syndrome, are actually a relatively minor contributor to hereditary ovarian cancer. And Dr. Norquist looked at mutations by age distribution. And what you can see here is that BRCA1 is the predominant gene that causes hereditary ovarian cancer in women in their 40s and even earlier. But mutations in other genes occur in the later ages and are not really earlier of age of onset than you would expect for ovarian cancer, in which the average age of diagnosis is around 60. She also looked at histology. So as I said, we have many histologies of ovarian cancer, and it turns out that mutations are present in all the histologies of ovarian cancer. There is a hereditary component, with a lower fraction in low-grade serous and a lower fraction in clear cell. But still, this led to this, prior to this, there were people saying we should be doing genetic testing for all women with high-grade serous ovarian cancer. And it's this work that really showed that all women with invasive ovarian cancer should be offered genetic testing. And this genetic testing should not be limited by the histology of their disease. And it should extend beyond BRCA1 and BRCA2 to other genes. And Dr. Norquist helped us define what is the penetrance of these genes. How likely is it to get ovarian cancer if you inherit a mutation in one of these genes, which is essential to the next step of being able to counsel these women about their risk and what they should do about that risk. And so with other authors listed here as well, most of these genes cause about a 5 to 10% in that range risk of ovarian cancer. And this is high enough to justify risk-reducing self-pinch oophorectomy, which is now in our national guidelines to consider between the age of 45 and 50 for women who inherit mutations in these genes. So, like I just told you that the cost of DNA sequencing had fallen. So it seems like we should be able to offer this test to all women to understand their hereditary risk of ovarian cancer. But at that time, there were patents on the genes BRCA1 and BRCA2, and the company, who will not be named for all you Harry Potter fans, charged over $4,000 for genetic testing for these 2 genes. And they also, at that time, because they had a monopoly, did not offer state-of-the-art testing, resulting in Americans paying more and getting less for their cancer genetic testing relative to what was happening around the rest of the world. So this brings me to my next lesson, which I learned from Dr. Mary Claire King, who had done her graduate work in Berkeley in the 60s, that it's important to stay focused, but don't stay in your lane. There is a role for science in advocacy and public policy. And I was able to be an expert witness in the Supreme Court case, unpaid, I'll say, for the ACLU, who basically brought the case that human genes should not be patented. And this ended up in 2013 as a Supreme Court decision that was actually unanimous. I know most of you probably don't realize that the Supreme Court ever has a unanimous decision, but a 9-0 unanimous decision that the human genes should not be patented. And the very next day, Colin Pritchard, who had worked with Dr. King to take BRCA and make it a a clinically available test through UW Lab Medicine, released a version of BRCA that had BRCA1 and BRCA2 on this panel of genes. So we were able to basically take what happened, even though it wasn't necessarily expected that this would be the resolution of this court case, and bring it right back to patients. So I'm going to switch gears and talk about the prevention aspect. So now we know that 20% of ovarian cancer is hereditary, and it really obligates us to define that risk, but also prevent it once that risk is identified. So risk-reducing salpingo-oophorectomy, it reduces the mortality for patients with BRCA1 and 2 mutations. Because ovarian cancer is so deadly, having the surgical prevention definitely reduces mortality. And it's recommended for women who have BRCA1 mutations at age 35 to 40, and for BRCA2 because the onset is a little bit later at age 40 to 45. But it has its negative effects, which is essentially related to surgical menopause. It impacts quality of life with menopausal symptoms, mood, sleep, hot flashes, and others. It impacts sexual function, and it impacts long-term health, including morbidity of the brain, the bone, and the heart. And so a lot of women are not enthused about going through surgical menopause at that age. So this brings me to my next tip, which is remember who you serve. Women, as we started publishing data on the fallopian tube hypothesis, patients started saying, well, can't you just remove my fallopian tubes then? Why do I need to have my ovaries removed? It's removing the ovaries that cause menopause, of course. And there's an advocacy group called FORCE, Facing Our Risk of Cancer Empowered, who pushed us as clinicians and scientists to start a surgical trial that would evaluate this question. But we were pretty reluctant because we knew we had an intervention that reduced mortality. And so we were somewhat reluctant. But advocates really pushed for the fact that women wanted more options. And so as part of our Stand Up to Cancer trial, I don't think this would have ever been funded by the NIH because it was, sort of out of the box. We started this trial called Women Choosing Surgical Prevention. And in this trial, women self-selected to have the standard surgery of risk-reducing salpingo-oophorectomy, or they could have what we call an interval salpingectomy and then a delayed oophorectomy, where they have their fallopian tubes out and then remove their ovaries later. We still would recommend at the recommended age, but some patients, postpone that later. And this was led by my close collaborator, Karen Liu at MD Anderson. And these were the sites where we enrolled patients on the WISP trial. And the primary objective of the trial was change in sexual function. And so that's what it was powered for, even though we would like to know the impact on cancer efficacy, the reduction in cancer. It wasn't, that would take thousands of patients. And so this trial was powered for the change in sexual function because that's important to women and was one reason that people delayed having their ovaries out. So looking at the female sexual function index shown, which breaks it down by different areas of sexual function, you can see here that women with the interval salpingectomy had lower change in sexual function. So we used patients as their own baseline. We measured their sexual function before surgery, and then we measured it at 6 months after surgery when they would have had plenty of time to equilibrate. And we compare this to the women who were having estrogen replacement therapy. So they were having hormone replacement therapy. And we eliminated the patients in this analysis that were not having hormone replacement therapy to take that aspect out of it. And there was significantly less worsening of sexual function in the patients who had the salpingectomy in basically every domain except pain, with the largest relative risk for change in sexual function being with desire and satisfaction. So what we can say about the WISP trial is that there was less detriment in sexual function in the women who chose that pathway. There was also higher quality of life, and we reported no post-surgical cancers. So we did have a close data safety monitoring plan for this trial. So that is basically the fact that this was a positive trial and it appeared safe in 400 patients. This has led to the NCI putting forward a larger trial just for BRCA1 carriers of over 2,200 patients that is actually powered for cancer outcomes. And this is led by our own Dr. Katie Pennington here at UW. And it's good that she's young because this trial is going to take 18 years to mature by the estimate. So we've also put together an international collaboration. We call it TubaWisp-2, which is allowing women to push back their oophorectomy by 5 years if they have their self-injectomy. And we're basically creating a large international consortium where people that are doing this trial in other countries, we can pool our data and hopefully get to the cancer outcome questions sooner. Okay, so we know what to do if somebody's identified with a genetic mutation, but how do we get women to have that testing done before they get cancer? There's no effective early detection. So identifying risk is critical, but there's a lot of barriers. And uptake of testing for those that are eligible based on current family history criteria is quite low. It's estimated to be not more than 20%. And even though genetic testing has been around for a long time, we're really not making much headway into getting more patients tested, despite the fact that testing has gotten cheaper and more available. So most of the cancer genetic studies are done in high-resource facilities under optimal conditions, and there's sort of many barriers to our current genetic testing paradigm, including multiple clinic visits and needing access to genetic counselors. So as another part of our Stand Up to Cancer program, we started a study called Magenta, which stands for Making Genetic Testing Accessible. And this was pre-pandemic, so it seems a little bit less novel right now. But we wanted to ask the question if we could deliver genetic testing to women in their homes. And we also wanted to answer the question, how much genetic counseling is optimal? Because the resources that are needed for that are pretty extensive with our current paradigm, but nobody had ever really tested how much counseling patients really need. So Magenta was a 4-armed trial where we randomized the amount of pre and post-test individual counseling that people got. So everybody got a sort of computer information, watched a video, and then some patients had mandatory pre-test counseling, and some patients had mandatory post-test counseling before they could get their genetic results. And it was powered to show non-inferiority. We had 2 groups of patients. We had a family history cohort, which was the main cohort for which we were powered. And we also had a cascade testing group, which were patients that were supposed to that had mutations in other family members and hadn't yet gotten tested. So patients could not have had previous testing or counseling. And also it was important that all patients that did have a pathogenic mutation did get individualized counseling, regardless of what arm they were in. So the primary outcome was distress at 3 months. And so we enrolled almost 4,000 patients to this study. And in the family history cohort, there was no increase in cancer worry and distress 3 months after the test, regardless of what arm people were in. So that was the harm that people were worried could happen if we dropped genetic counseling. So another kind of important part of the study is that we wanted to look at the completion rate. So it turns out that all the completion rates were non-inferior too. This is a non-inferiority study, but the highest rates of completion were in the 2 arms in which pretest counseling was not required, which is notable. So that paper is out for review right now, and there's a lot more data from that trial. But now we know that we can make cancer genetic testing cheaper and that less pretest genetic counseling is not harmful. But can we improve implementation into clinical practice? So I paired up with Dr. Deborah Bowen to apply for one of the Moonshot grants, which was addressing genetic risk assessment. And we have a trial that's going on right now in multi-care and in the Billings healthcare systems where clinics are randomized to one of 2 interventions where we try to make it easier to identify patients and get genetic testing to them. And what's notable in this trial is that the primary care provider doesn't have to be involved until the test is resulted. And so what we're trying to do is not burden the primary care provider, but provide an easier way to get patients through genetic testing in the clinic. So more to come on that. So our goal now, I think that we're getting closer to saying, our goal is to really eliminate hereditary ovarian cancer. And I just do want to bring up that Dr. Barbara Norquist is my partner on that journey. And I think she'll be the one that sees it to completion. So we could say that now, what's the progress that we've made in that goal? We do understand, I think, nearly all hereditary ovarian cancer genes and the risk associated with mutations in those genes. We can define the pathophysiology of the cancers that evolve. We've developed effective and potentially acceptable surgical prophylaxis options. And we can make genetic testing cheap and accessible. But there's still quite a lot of work to be done. So what are the things that we still need to do? Well, population testing for cancer risks. So this is something that Dr. King has promoted and other people, and really to really bypass the primary care system and the clinic and get this out to all people. This should just be a routine test that people get. At least once in your lifetime, get tested for all cancer genetic risk and not wait until people get cancer to offer genetic testing. But an important aspect of this is we need to decrease disparities of access to genetic information and technology. So testing has gotten cheaper, but we actually haven't bridged the divide between patients with less resources are less likely to get this information and get tested, much less cancer prevention and follow-up. And we really haven't addressed early detection and surveillance yet. And understanding where these cancers come from has changed the paradigm. Why should we be ultrasounding the ovary if that's not even where the cancer arises? So more to come on this. And I do have a lot of collaborators working in this area.
Sorry, I changed my headphones. I don't know what happened with cheap headphones. I'm sorry. So we're getting towards the end, so this is good. So get back to my original project, which was accessible in the lab. Does BRCA promoter methylation impact response to therapy, and does it change over time during treatment? So I just want to tell you, not everything in science is easy, of course. And this was really what I thought was a relatively easy project, but it honestly was a 10-year struggle to get this published. And my next tip is publish it anyway. Don't get deviated. It doesn't matter how long it takes, get it out there. And sometimes that leads to good things eventually. And so at the same time, there were these development of these drugs called PARP inhibitors came along, and PARP inhibitors, these were two seminal papers in Nature that came out in 2005 that showed that PARP inhibitors selectively kill cells that have defects in homologous recombination repair, and specifically cancers that are deficient in BRCA1 and BRCA2 are particularly sensitive to PARP inhibitors. And that coined a phrase called synthetic lethality, which actually has led to an entire biotech launch of different companies in this area. So 3 PARP inhibitors are approved in ovarian cancer, and this could be a whole talk of its own, and some people have heard me talk on this. And all I'm going to say here is that for women with BRCA1 and 2 mutations, this has massively changed their outcomes for ovarian cancer. And this is data from the SOLO-1 trial published in the New England Journal in 2018 by Katie Moore and colleagues. And so working in this area of BRCA1 methylation and did it impact response to treatment got me down this road with PARP inhibitors, looking at predictors of response and resistance to PARP inhibitors. And in fact, we launched a clinical trial to try to understand biomarkers in collaboration with my awesome mentor, Scott Kaufman from the Mayo Clinic. And so my next tip for clinician scientists is good ideas remain good ideas, also known as timing is everything and don't let go of good science. And so I did not have the assays worked out and the biology and the treatment to make my first paper very impactful. But I currently have 2 R01s looking at BRCA1 methylation in relation to PARP inhibitor therapy. Izzy Rodriguez is working on a project for which she's going to give a plenary talk at the SGO. And members of my lab have worked on this over the years, and now hopefully we're working with lab medicine and going to launch a clinical test in the very near future. So what goes around comes around. So just getting back to this, ovarian cancer is heterogeneous. I hope I've given you an idea how we are moving towards personalized medicine by understanding that biology in both early detection and prevention, as well as therapy. And just from the news today, I just going to, brought me up that there's a tip. Lindsay Jacopoulos, if you guys haven't seen, she won the gold medal last night. And one important thing is let go of guilt. We all make mistakes, but it's important to move forward, try to live a good life, and you'll make an impact. I want to thank, Mary Claire King, of course, is my long-term mentor, and Barbara Goff, who's my departmental chair. I wouldn't be here without those two women who have been incredibly strong influences, and Heidi Gray, my division director. Without support from a clinical division, there is just no such thing as a clinician scientist. My next tip is find great collaborators, some of which are shown here. Not all of my collaborators, but these have been some of the really important collaborators that I have worked with over the years. And it becomes a family. And last, but definitely not least, is my own lab, the Swisher Lab. Follow us on Twitter. We don't have enough followers. The next step, my very last step, is build a team and treat them well, because these are my peeps, and I love them a lot. So I'm happy to take questions. Glad that you can hear me.
Yeah, outstanding, Liz. Let's see how some questions pop up, but let me just comment. I mean, really what you've done here in addition to displaying just an outstanding track record of science that really had an impact on patient outcomes, but I really appreciate the advice that you've given to, budding physician scientists. It's a tough road to hoe, but your comment right at the beginning about going from bedside to bench rather than the other way, I think in my experience is just spot on. One of the really wonderful things that physician scientist brings is shot selection. What problem to tackle, how. And then you also really illustrated that very nicely by looking not just at the biology of cancer, but the sociology, the patient's life. With the later, surgical trials of randomizing patients, kind of, and against, as you said, what a surgeon would choose to do, but listening to that patient population in order to really work together to get to the really the best patient outcome. So that was just great. And we're seeing comments along those lines. I'd like to see if there are any other questions that Liz should address. I think you just got a whole lot of fans out there, but I think you began with a whole lot of fans.
Barbara Goff
oh, okay, good.
threw me a softball. So Barbara Goff says, is population testing being done in Israel? And if so, what are the results that have been shown? And yes, population testing has been done in Israel for patients because BRCA1 and 2 mutations there's some founder mutations more common in that population. And it's even been done in an Ashkenazi population in London as well. And those results have really shown that it's acceptable to patients and it's relatively easy to implement. These are with a limited number of mutations, but now a lot of larger studies are going on, basically looking at more genes and all the possible mutations. It's been modeled that it's cost effective to do this compared to, compared to doing the cancers, but I think that this will be implemented in national healthcare kind of situations before it is in the US, where they're much better at doing prevention than we are, because it's a long-term cost savings, not an immediate cost savings. But yeah, it's being done even within healthcare systems in the US, like Kaiser and things. There are studies going on doing that.
Great, thank you. I guess, what suggestions do you have for all of us to advocate towards getting better penetrance of genetic screening across diverse populations?
Yeah, so I really welcome partnership in that area because I think we really need, I've talked with Kimmy Dole about this. I think we really need to do more community outreach and get into the, and find out like what are the acceptable ways to transmit information, the information that's missing. So I think a lot more work needs to get done to figure out how best to do that. I don't think we did very well just with COVID vaccines. So, so I think there's a lot that there's a lot of work, and this could be, we just really need talented people in this area to help overcome this barrier.
So Liz, let me just say once again, thank you very much. This was really tremendous. You do have tons of fans here that are commenting on your career as a physician scientist. But I think they're under recognizing your career as an audiovisual technician and your store of spare parts to be able to switch headphones and microphones and continue. So there's more to be seen. Thank you very much.
Thank you, Dr. Slattery.
Yeah. Bye-bye.
Thanks, everybody. Appreciate it.